Good morning, everyone. I'm going to be presenting this today in partnership with my colleague Anne, who will join us about halfway through this presentation. So as with all the presentations, we've got the acronyms at the beginning. I'm sure you all are familiar with these, so I'm going to kind of zip through these slides. It is our hope that after this training, you'll be able to demonstrate an understanding of the standardized items in Section GG, Functional Abilities and Goals, describe the intent, coding instructions, and definitions for Section GG items, and apply coding instructions to accurately code practice scenarios and the case study. So as with Terry's presentation and the icebreaker activity that you guys did this morning, we are going to be using Slido pretty heavily. So if you haven't yet logged in, I strongly encourage you to do so in order to gain, the maximum benefit of this presentation. So in 2014, the IMPACT Act was passed, and that's the Improving Medicare Post-Acute Care Transformation Act. And in 2016, Section GG was developed in an effort to sort of result in uniformity, which, as you can see on this diagram here, across all 4 PAC settings. So that's in IRFs, SNFs, LTACs, and home health agencies. And the intent specifically for IRFs is that patients in IRFs have self-care and mobility limitations and are at risk for further functional decline and complications due to limited mobility. So with Section GG, there's really 4 items we focus on. Prior functioning and everyday activities, which is assessed on admission. Prior device use, which is also assessed on admission, and then GG 0130 self-care and GG 0170 mobility, which address the need for assistance with self-care and mobility activities and are assessed on admission and discharge. So with GG 0100 prior functioning, the rationale for this is that it gives the clinicians knowledge of the patient's functioning existing prior to the current illness, exacerbation, or injury and may inform treatment goals. And this item is used in the risk adjustment for the quality measures. So you'll see here, this is what it looks like on the item set. On the right-hand side, you have different groups of activities, which we'll go through in detail, and the definitions of those. And then on the left-hand side, you have the coding. So often clinicians won't have a lot of detail in terms of what the patient's ability was immediately prior to the illness that occurred, and we'll talk about the steps to obtain the information in just a few moments. So what you would do in that scenario. So GG 0100A is self-care, which is defined as code the patient's need for assistance with bathing, dressing, using the toilet, or eating prior to the current illness, exacerbation, or injury. GG 0100B is indoor mobility or ambulation, and this is coding the patient's need for assistance with walking from room to room with or without an assistive device, such as a cane, crutch, or walker, again, prior to the current illness, exacerbation, or injury. GG 0100C, stairs, is code the patient's need for assistance with internal, external stairs, with or without an assistive device, such as a cane, crutch, or walker, again, prior to the current illness, exacerbation, or injury. And then GG 0100D, functional cognition. You would code the patient's need for assistance with planning regular tasks such as shopping or remembering to take medication prior to the current illness, exacerbation, or injury. So the steps for assessment when you're coding those 4 activities is interviewing the patient or their family members, or reviewing the patient's and reviewing the patient's medical records for details describing the patient's prior functioning with everyday activities. It's mostly self-report by the patient and family, but of course you can always look at the medical record to gain additional insight and check if it's been documented. In terms of coding instructions, you'd record the patient's usual ability to perform self-care, indoor mobility, ambulation, stairs, and functional cognition prior to the current illness, exacerbation, or injury. And just a quick note that these coding responses do differ from the 6-point scale and the activity not attempted codes. So they are listed here on this slide. Code 3, independent, if the patient completed the activities by him or herself with or without an assistive device with no assistance from a helper. So if a patient needed a walker or a cane, you could still code 3, independent. Code 2 needed some help if the patient needed partial assistance from another person to complete the activities. Code 1, dependent, if the helper completed the activities for the patient or the assistance of 2 or more helpers was required for the patient to complete the activities. You would code 8, unknown, if the patient's usual ability prior to the current illness, exacerbation, or injury is unknown. And code 9, not applicable, if the activity was not applicable to the patient prior to the current illness, exacerbation, or injury. And again, as I just said, if you don't have information about the patient's ability, even after attempts to interview the patient and his or her family, and after reviewing the medical record, you have that 8, unknown option. Okay, we're going to move on to prior device use now. So again, the rationale for this item is it gives the clinicians knowledge of the patient's routine use of devices and aids immediately prior to the current illness, exacerbation, or injury, and may inform treatment goals. And this item is also used in the risk adjustment of the quality measures. So for prior device use, we have a limited list here of mobility devices, and they are manual wheelchair, motorized wheelchair and or scooter, mechanical lift, walker, orthotics or prosthetics, or Z, none of the above. And the steps for assessment, again, interviewing the patient and the family, reviewing the patient's medical records, describing the patient's use of prior devices and aids. And again, you would only report devices and aids used immediately prior to the current illness, exacerbation, or injury for this section as well. For coding instructions, you would check all the devices that apply, so listed here A through E. If you do check Z, none of the above, this means that none of the devices listed A through E were used. GG0110 mechanical lift, this is any device a patient or caregiver requires for lifting or supporting the patient's body weight. A limited list of examples are on this slide, and they are stair lift, Hoyer lift, or bathtub lift. For GG0110 walker, we do include all walker types, and the examples, again, listed here, but this is not an exhaustive list, we'll say. So there are pickup walkers, hemi walkers, rolling walkers, platform walkers, four-wheel walkers, rollator walkers, knee walkers, and walkers for mobilizing while seated in a walker. So one question we got from the last training we did in May, and several times on the help desk we've gotten this question too, so we decided to include it here for you all. Why is a cane not included in the list of prior devices? And our answer is the devices listed in the item GG0110 prior device use are included on the Inpatient Rehab Facility Patient Assessment Instrument because they are risk adjusters for the functional outcome measures. During the development of the functional outcome measures, testing was conducted to determine if prior use of a cane or crutches affected either self-care or mobility outcomes. CMS found that these devices did not affect functional outcomes. For that reason, CMS did not include these items on the list of devices. If the patient was using a cane or crutches prior to the current illness, exacerbation, or injury, and none of the devices listed, you would code GG0110 prior device use as Z, none of the above. So we are going to go through a practice coding scenario, and this video that you're going to watch is actually occurring in an ADL suite in an IRF, and so you might notice that the environment appears more home-like for that reason.
Let's watch a scenario of an assessing clinician collecting information from multiple sources to code GG0110 prior device use.
I noticed you have a few different devices here, Mr. Smith. Which of these were you using to help you walk just before you went to the hospital?
I wasn't using anything. I was walking on my own.
How's it going? Can I help answer anything?
I was just asking your husband which of these devices he used to help him walk before going to the hospital.
Oh, he was using that cane over there to help him get around.
Oh, yeah, I guess I was using that.
Okay, good. It also says here in your hospital discharge paperwork that you're using a walker before you were admitted. Is that right?
Yeah, I guess I used that when I went outside.
Okay. And I see a wheelchair over there. Were you also using that?
No, that's mine. I was using it when I had chemotherapy last year.
Okay, thank you for clarifying. And were you using anything else like a shoe insert or a chairlift in another room, anything like that?
No, that's all, just what I told you.
Okay, so you guys will now have the opportunity to practice this on Slido. So how would you code GG0110 prior device use? Your choices are A, manual wheelchair, check D, walker, C, check both A, manual wheelchair, and D, walker, or D, check Z, none of the above. I'll give you guys just a few more seconds to get those responses coming in. Good, and we'll go ahead and take a look at the correct answer now. And it is, in fact, D, walker. The rationale behind that is the clinician used multiple sources of information to determine that Mr. Smith was using a walker and a cane prior to his recent hospitalization. So if the clinician hadn't asked Mrs. Smith about what the patient was using before, there's a chance that he may have gotten inaccurate information and would have coded that incorrectly. So prior use of a cane, as we mentioned earlier, is not captured in GG0110, so only option D, walker, should be checked. And devices coded for prior device use may be used indoors and or outdoors. All right, we're going to go ahead and get started with GG0130 self-care, and then Anne's going to take over for mobility. So I'll talk quickly through the intent. So GG0130 self-care identifies the patient's ability to perform the listed self-care activities and discharge goals, and GG0170 identifies the patient's abilities to perform the listed mobility activities and discharge goals. So for the steps for assessment for both of these sections, you would assess the patient's self-care and mobility performance based on direct observation, the patient's self-report, and reports from clinicians, care staff, or family reports, documented in the patient's medical record during the 3-day assessment period. And there is an emphasis placed on 3-day assessment period. You're going to hear me say that over and over again in my presentation. So patients should be allowed to perform activities as independently as possible as long as they are safe. And it is important to give patients the time they need to complete the activity on their own to accurately code their abilities. If help or assistance is required because a patient's performance is unsafe or of poor quality, you would score based on the type and amount of assistance provided. Activities can be completed with or without an assistive device, and use of the assistive device to complete the activity should not affect coding of the activity. Continuing with the steps for assessment, we ask clinicians to refer to facility, federal, and state policies and procedures to determine which IRF staff members may complete an assessment. Patient assessments are to be done in compliance with facility, federal, and state requirements. So as promised, I'm going to talk again about the 3-day assessment period. So the admission assessment period is the day of admission, the following 2 days, ending at 11:59 p.m. officially on day 3. So let's say, for example, somebody came into your facility today. They'd have the balance of today, tomorrow, and then officially until 11:59 p.m. the day after tomorrow. For the discharge assessment period, it's the day of discharge and the 2 calendar days prior to the day of discharge. So I'd like to discuss usual status next. So for admission, the patient's functional status should be based on a clinical assessment of the patient's performance that occurs soon after the patient's admission. The admission function scores are to reflect the patient's admission baseline status prior to any benefit from therapeutic interventions. For discharge, you want to code the patient's discharge functional status based on a clinical assessment that occurs close to the time of discharge. And one thing, just really quick with the admission, you don't want to withhold treatment in order to conduct the functional assessment. It is important to continue with that. So a patient's functional status can be impacted by the environment or situations encountered at the facility. Observing the patient's interactions with others in different locations and circumstances is important for a comprehensive understanding of the patient's functional status. If the patient's status varies, record the patient's usual ability to perform each activity. You would not record the patient's best performance and worst performance. Instead, record the patient's usual performance. And usual performance does require some degree of clinical judgment, so that's important to remember when you're coding for that. Okay, so GG0130 and GG0170 have the same coding instructions in the 6-point scale. They're listed here. Code 06 is independent. 05 is setup or cleanup assistance. 04, supervision or touching assistance, and that does include contact guard as well. 03 being partial or moderate assistance. 02, substantial or maximal assistance, and 01, dependent. We are going to watch a video now on the decision tree, which will review each coding option in the 6-point scale in greater detail. It's going to go through using an example of a patient, Mrs. Jones, completing GG0170D, sit to stand.
We will walk through the decision tree for coding GG0130, self-care, and GG0170, mobility, highlighting each coding level using an example of a patient, Mrs. Jones, completing GG0170D, sit to stand. The decision tree presents a series of yes-no questions, represented by diamonds, that guide you to the correct code for your patient or resident. Accurate coding is important to capture patient and resident safety, appropriate goal setting, and accurate evaluation of the patient's or resident's functional ability at discharge. The first question in the decision tree asks, does the patient or resident complete the activity, with or without assistive devices, by him or herself and with no assistance, including physical, verbal, or nonverbal cueing, setup, or cleanup? If the answer to this question is yes, the correct code for this patient or resident is 06, independent. Let's view an example of Mrs. Jones completing the sit-to-stand activity independently. In this scenario, Mrs. Jones is sitting up on the side of the bed. She retrieves her walker and places it in front of her. Then, she safely rises to a standing position. Once standing, she holds on to the walker to steady herself. There is no assistance provided by a helper. If, however, the answer to this first question is no, the patient or resident is not able to complete the activity by him or herself without assistance, proceed to the next question. The second question in the decision tree asks, does the patient or resident need only setup or cleanup assistance from one helper? If the answer to this question is yes, the correct code for this patient or resident is 05, setup or cleanup assistance. Let's review an example of the same patient, Mrs. Jones, completing the sit-to-stand activity, but this time with setup or cleanup assistance. In this scenario, Mrs. Jones is sitting up on the side of the bed. She retrieves her walker and places it in front of her. Then, a helper raises the bed rail. Mrs. Jones grasps the bed rail and safely rises to a standing position. Once standing, she holds onto the walker to steady herself. In this example, the patient completes the activity by herself with setup assistance. Setup assistance is demonstrated by the helper raising the bed rail. So, you would code this 05, setup or cleanup assistance. If, however, the answer to this question is no, the patient or resident requires more than setup or cleanup assistance to complete the activity, proceed to the next question. The third question in the decision tree asks, does the patient or resident need only verbal or nonverbal cueing, or steadying, touching, or contact guard assistance from one helper? If the answer to this question is yes, the correct code for this patient or resident is 04, supervision or touching assistance. Let's review an example of the same patient, Mrs. Jones, completing the sit-to-stand activity, but this time with supervision or touching assistance. In this scene, Mrs. Jones is sitting up on the side of the bed. She retrieves her walker and places it in front of her. Then, a helper raises the bed rail and provides cues for hand placement.
I'm going to tell you how to do it safely.
The helper also provides instructions to help Mrs. Jones safely rise to a standing position. Once standing, Mrs. Jones holds onto the walker to steady herself. In this scenario, Mrs. Jones needs verbal and nonverbal cueing from one helper, so you would use code 04, supervision or touching assistance. If, however, the answer to this question is no, the patient or resident requires more than supervision or touching assistance to complete the activity, proceed to the next question. The fourth question in the decision tree asks, does the patient or resident need physical assistance, for example, lifting or trunk support, from one helper with the helper providing less than half of the effort? If the answer to this question is yes, the correct code for this patient or resident is 03, partial moderate assistance. Let's review an example of Mrs. Jones completing the sit-to-stand activity, but this time with partial moderate assistance. In this scene, Mrs. Jones is sitting up on the side of the bed. She retrieves her walker and places it in front of her.
Mrs. Jones.
Oh, good morning.
A helper raises the bed rail, secures a gait belt around her waist, and provides instructions regarding the transfer.
One hand on the rail. You're going to put one hand on the bed. We're going to go on the count of 3, all right?
Then, while holding Mrs. Jones, the helper provides a slight upward boost using the gait belt. Mrs. Jones, who is bearing most of the weight, rises safely to a standing position. In this example, Mrs. Jones needs physical assistance with the helper providing less than half of the effort, so you would code this 03, partial moderate assistance. If, however, the answer to this question is no, the patient or resident requires more than partial moderate assistance to complete the activity, proceed to the next question. The fifth question in the decision tree asks, does the patient or resident need physical assistance, for example, lifting or trunk support from one helper, with the helper providing more than half of the effort? If the answer to this question is yes, the correct code for this patient or resident is 02, substantial maximal assistance. Let's review an example of the same patient, Mrs. Jones, completing the sit-to-stand activity, but this time with substantial maximal assistance. In this scene, Mrs. Jones is sitting up on the side of the bed. She retrieves her walker and places it in front of her. A helper raises the bed rail, secures a gait belt around Mrs. Jones' waist, and provides instruction regarding the transfer.
We're going to work together.
Okay.
Okay, on the count of 3.
3.
Okay.
Using the gait belt, the helper lifts Mrs. Jones, bearing most of her weight during the transfer.
1, 2,
2.
3.
The helper provides continual assistance as she moves Mrs. Jones to a standing position. In this scenario, Mrs. Jones needs physical assistance with the helper providing more than half of the effort, so you would code this 02, substantial maximal assistance. If, however, the answer to this question is no, the patient or resident requires more than substantial maximal assistance from one helper to complete the activity, proceed to the next question. The sixth and final question in the decision tree asks, does the helper provide all the effort to complete the activity, or is the assistance of 2 or more helpers required to complete the activity? If the answer to this question is yes, the correct code for this patient or resident is 01, dependent. Let's review a final example of the same patient, Mrs. Jones, completing the sit-to-stand activity, but this time the patient is dependent on 2 helpers to complete the activity. In this scene, 2 helpers are assisting Mrs. Jones. One helper secures a gait belt around Mrs. Jones' waist, while the other helper provides instructions about the transfer.
On 3, we're going to stand up. 1, 2, 3, all the way up tall.
Both helpers provide continual assistance as they move Mrs. Jones to a standing position, using the gait belt to fully support her weight. Once standing, Mrs. Jones holds onto the walker to steady herself. In this scenario, Mrs. Jones needs the physical assistance of 2 or more helpers to complete this activity, so you would code this 01, dependent. This video provided you with an overview of the decision tree for coding GG0130 Self-Care and GG0170 Mobility. We reviewed a series of key coding questions to help you identify the correct code for your patient or resident. Accurate coding is important to capture patient and resident safety, appropriate goal setting, and accurate evaluation of the patient's or resident's functional ability at discharge. We hope you found this video helpful. For more information on coding section GG, refer to your setting-specific guidance manual that can be found on the CMS website.
Great, and just a quick note for those of you in the room, in your folders, you do have a decision tree. It's handout number 7, and it will probably be useful to have as we go through some of the practice coding scenarios. So if you want to go ahead and pull that out while I talk through these next few slides. So in the situation that an activity was not attempted, and that is during the entire 3-day assessment period, if the patient does not attempt the activity and a helper does not complete the activity for the patient, you would code the reason the activity was not attempted. And the 4 activity not attempted codes are listed here on this slide. They are 07, patient refused. And so in this situation, the patient refused to complete the activity. 09, not applicable, which means it's not attempted and the patient did not perform this activity prior to the current illness, exacerbation, or injury. Code 10, which is not attempted due to environmental limitations. So for example, lack of equipment or weather constraints. Or code 88, not attempted due to medical condition or safety concerns. And this implies that activity was not attempted due to medical conditions or safety concerns. So one of the provider Q&As that came in is, can you provide scenarios in which a patient would be scored 10 for an item? And this is again based on help desk questions and prior training questions. So our answer is we do not expect code 10 not attempted due to environmental limitations to be used often. If a patient is unable to go outside due to inclement weather, such as snow or cold temperatures, and no indoor option for uneven surfaces available, code GG0170L, walk 10 feet on uneven surfaces with code 10, not attempted due to environmental limitations. For GG0170R, wheel 50 feet with 2 turns. If a patient is obese and you do not have a wheelchair that is the appropriate size for the patient, you would code 10, not attempted due to environmental limitations due to the lack of equipment. Okay, just some general coding tips when assessing GG0130 and GG0170. When reviewing the patient's medical record, interviewing staff, and observing the patient, be familiar with the definition of each activity. So you'll notice when we go through the coding scenarios, I will read the definition to you all just to get into that practice mode. It's very helpful when you're assessing the activity then if you know what the definition is. Code based on the patient's performance. Do not record the staff's assessment of the patient's potential capability to perform the activity. And to clarify your own understanding of the patient's performance of an activity, ask probing questions to the care staff about the patient, beginning with the general and proceeding to the more specific. Continuing with coding tips for GG0130 and GG0170, documentation used in the medical record to support assessment coding of section GG. Data entered should be consistent with the clinical assessment documentation in the patient's medical record. Use of assistive devices to complete an activity should not affect coding of the activity. So if a patient uses adaptive equipment and uses the device independently when performing an activity, you would enter code C06 independent. If the only help that a patient needs is to complete an activity is for a helper to retrieve an assistive device or adaptive equipment, such as a cane for walking, then enter code 05 setup or cleanup assistance. And if 2 or more helpers are required to assist the patient in completing the activity, you can automatically skip to code 01 dependent. Anytime 2 or more helpers are required, you do go straight to 01 dependent. So for patients with incomplete stays, such as a patient with an emergency discharge, the self-care and mobility items are skipped. Patients with incomplete stays include patients who unexpectedly discharge to an acute care setting, and that is a short stay acute care hospital, critical access hospital, inpatient psychiatric facility, or a long-term care hospital, patients who die or leave the IRF against medical advice, and patients with a length of stay of less than 3 days. So another opportunity for Slido, which example below best demonstrates allowing the patient to function as independently as possible? Is it A, feeding a patient who can feed himself in order to expedite mealtime? B, allowing the patient to brush her teeth as much as possible, assisting only if she becomes fatigued? C, providing the patient with a bedside commode when he's capable of walking to the bathroom with assistance? Or D, all of the above? We are seeing a lot of people entering in B. Let's go ahead and take a look at what the correct answer is. And it is, in fact, B, allowing the patient to brush her teeth as much as possible, assisting only if she becomes fatigued. The reason for this is it allows the patients to achieve their goal toward independence. It also allows her to participate in the activity to the fullest extent possible, only receiving assistance from the caregiver as needed. Patients should be allowed to perform activities as independently as possible, again, as long as they are safe. And facility staff and/or family should allow independence whenever possible to promote quality of life and a sense of well-being. We're going to do a true-false question now on Slido. So since Mr. W uses a quad cane, he cannot be considered independent for the Section GG walking items. Is this A, true, or B, false? A lot of rapid movement towards false. Let's take a look at what the correct answer is. And it is, in fact, B, false. And the rationale behind this is activities, again, can be completed with or without an assistive device. Use of assistive device to complete an activity should not affect the coding of activity. All right, so we're going to get started with self-care. We'll start with GG0130A. This is what it looks like, again, on the item set. You have 2 columns, admission, performance, and discharge goal. So the definition of GG0130A eating is the ability to use suitable utensils to bring food and or liquid to the mouth and swallow food and or liquid once the meal is placed before the patient. So some coding tips. If a patient receives tube feeds or parenteral nutrition, assistance with tube feedings or PN is not considered when coding the item eating. If the patient does not eat or drink by mouth and relies solely on nutrition and liquids through tube feedings or PN due to a new, and that is a recent onset medical condition, you would code GG0130A as 88, not attempted due to medical conditions or safety concerns. So continuing with coding tips for eating, if the patient does not eat or drink by mouth at the time of the assessment, and the patient did not eat or drink by mouth prior to the current illness, injury, or exacerbation, you would code GG0130A as 09, not applicable. And if the patient eats and drinks by mouth and relies partially on obtaining nutrition and liquids via tube feedings or PN, you would code eating based on the type and amount of assistance the patient requires to eat and drink by mouth. So our practice scenario is for the past 2 years, Ms. T has been unable to eat or drink by mouth due to a swallowing disorder and a history of aspiration pneumonia. She uses a gastrostomy tube, G-tube, to obtain nutrition. Miss T had a stroke 8 days ago, and her IRF admission orders include nothing by mouth and PO and G-tube feedings. How would you code GG0130A? Is it A, 01, dependent, B, 02, substantial or maximal assistance, C, 09, not applicable, or D, 88, not attempted due to medical condition or safety concerns? And I'm hearing the answer. I'm seeing it on Slido. Let's go ahead and take a look at what the correct answer is. And it is 09, not applicable. The rationale behind this, as I mentioned during the coding tips, Ms. T does not eat or drink by mouth at the time of the admission assessment, and she did not eat or drink by mouth prior to the current illness, injury, or exacerbation. Eating includes only eating by mouth, and assistance with G-tube feedings or PN are not considered when coding this item. All right, we're going to move now to oral hygiene. The definition for this activity is the ability to use suitable items to clean teeth. Dentures, if applicable, the ability to insert or remove dentures into and from the mouth and manage denture soaking and rinsing with the use of equipment. So we have a video here in which we're going to talk through the practice coding scenario on oral hygiene.
Here you see the helper providing steadying assistance to Mr. Smith as he walks to the bathroom using his walker. Once in front of the bathroom sink, the helper applies toothpaste to Mr. Smith's toothbrush and leaves the room. Mr. Smith then brushes his teeth without supervision. Once Mr. Smith is done brushing his teeth, the helper re-engages by cleaning and putting away the oral hygiene items. The helper then provides steadying assistance to Mr. Smith as he walks back to bed.
In this situation, oral hygiene would be coded O5, setup or cleanup assistance. And the reason being the helper provided setup assistance by putting toothpaste on the patient's toothbrush and cleanup assistance by putting away the supplies after the patient completed the activity. We wouldn't consider the assistance getting to and from the bathroom because we're coding oral hygiene. So we'll watch another video on this. This is a little different even though it's the same patient, and we are going to have a Slido question following this to see how you guys do.
Here you see the helper providing assistance to Mr. Smith as he walks to the bathroom. Once in front of the bathroom sink, the helper retrieves and puts toothpaste on Mr. Smith's toothbrush and hands it to him. The helper then steadies Mr. Smith's arm as he brushes his teeth. Once Mr. Smith is finished brushing his teeth, the helper rinses his toothbrush and puts it away. The helper then provides steadying assistance as Mr. Smith walks back to bed.
So based on what you guys just saw, how would you code GG0130B? Would it be A, O5, setup or cleanup assistance, B, O4, supervision or touching assistance, C, O3, partial or moderate assistance, or D, O2, substantial or maximal assistance? You guys are doing really well. So let's take a look at what the correct answer is now. And it is B, supervision or touching assistance. So again, Mr. Smith required the helper to provide supervision and touching assistance in order to complete the activity of oral hygiene. We wouldn't consider the assistance getting to and from the bathroom. Next, we have GG0130C, toileting hygiene. This is the ability to maintain perennial hygiene, adjust clothes before and after voiding or having a bowel movement, and if managing an ostomy, include wiping the opening but not managing the equipment. So our practice coding scenario for GG0130C, Mr. W uses a urinal when voiding and completes toileting hygiene tasks without assistance while sitting on the side of the bed. He uses a toilet with a raised toilet seat when moving his bowels and requires contact guard assistance from the helper as he holds onto a grab bar with one hand, lowers his underwear and pants, performs perianal hygiene, and then pulls up his underwear and pants. So based on that information, how would you code GG0130C? Your options are A, O2, substantial or maximal assistance, B, O3, partial or moderate assistance, C, O4, supervision or touching assistance, or D, O6, independent. And the answer is O4, supervision or touching assistance, the reasoning being the helper provides contact guard assistance as the patient completes the activity. Next, we have GG0130E, shower bathe self. This is defined as the ability to bathe self, including washing, rinsing, and drying self, excludes washing of the back and hair, and it does not include transferring into or out of the tub or shower. So some more coding tips here for GG0130E. Assessment can take place in a shower or bath or at a sink, so that would be a full body sponge bath. If the patient bathes himself or herself and a helper sets up materials for bathing or showering, you would code O5, setup or cleanup assistance. If the patient cannot bathe his or her entire body because of a medical condition, you would code based on the type and amount of assistance needed to complete the activity. So now we have our practice coding scenario for GG0130E. Ms. N declines to shower herself when the occupational therapist attempts to complete the assessment. The therapist asks Ms. N's CNA detailed questions about Ms. N's ability to shower and bathe herself and considers this input when coding the activity. The therapist learns that Ms. N takes a shower and initiates washing her face, arms, chest, part of her legs, and perineal area. She requires assistance to wash, rinse, and dry her lower extremities below the knees. Miss N rinses and dries most of her body. So based on this, how would you code GG0130E? Your options are A, 04, supervision or touching assistance, B, 03, partial or moderate assistance, C, 02, substantial or maximal assistance, or D, 01, dependent. And again, you guys are doing really well. Let's look at the correct answer. It is B, 03, partial or moderate assistance. This is because the helper provides less than half the effort for Miss N to complete the activity of shower bathe self. During the 3-day assessment period, the therapist does not observe the patient bathing and asks other clinicians and care staff of Miss N's abilities. Next, we have GG0130F, upper body dressing. This is the ability to dress and undress above the waist, include fasteners if applicable. So on this slide here, we have some examples of upper body dressing items. You would assess the patient based on the clothing the patient routinely wears. And this is not an exhaustive list. There are definitely more upper body dressing items than what's listed here. This is just to give you guys an idea. Okay, so practice coding scenario for GG0130F upper body dressing. Mr. T has reduced strength and range of motion in both upper extremities following spinal surgery, and he wears a cervical collar. The nurse puts on the cervical collar. Once Mr. T is sitting at the side of the bed, he threads his hand into the sleeve of his shirt, and due to his no twisting precautions, the nurse pulls the shirt across his back and threads his other hand into the shirt sleeve. The nurse also pulls up the shirt over both shoulders. Mr. T buttons 2 of his shirt buttons, and the nurse buttons the last 3. So based on this, how would you code GG0130F? Your options are A, 04, supervision or touching assistance, B, 03, partial or moderate assistance, C, 02, substantial or maximal assistance, or D, 01, dependent. And I know we're going through these relatively quickly, but I hope you are getting the opportunity to use the decision tree too if you're stuck. We'll go ahead and look at the correct answer, and it is C, 02, substantial or maximal assistance. The reason being Mr. T threads one arm into his shirt sleeve and buttons up some of his buttons. The nurse assists Mr. T by applying the cervical collar and helping him to pull his shirt around his back, threading his other arm and pulling it over his shoulder and buttoning some of the buttons. So the nurse clearly does a lot in this situation. And for dressing items, you consider donning and or doffing an orthosis or prosthesis or other device as a piece of clothing when dressing or undressing. All right, we'll move now to lower body dressing. The definition for lower body dressing is the ability to dress and undress below the waist, including fasteners, and it does not include footwear. So as with upper body dressing, we've got some lower body dressing examples on here. Again, please note these are some examples, and you would assess the patient based on the clothing they routinely wear. So here's a practice coding scenario for GG0130G. So Mrs. R has peripheral neuropathy in her upper and lower extremities. She needs assistance from a helper to place her lower limb into and take it out of her lower limb prosthesis. She needs no assistance to put on and remove her underwear or slacks. So based on this information, how would you code GG0130G? Your options are A, 02, substantial or maximal assistance, B, 03, partial or moderate assistance, C, 04, supervision or touching assistance, or D, 06, independent. And we'll go ahead and take a look at the correct answer now. And it is, in fact, B, 03, partial or moderate assistance. Reason being, a helper performs less than half the effort of lower body dressing. And again, just as I mentioned with upper body dressing, assistance with the lower extremity prosthesis is considered when assessing lower body dressing. So we do have another provider Q&A. This one says, if a patient does not have clothing on the day of admission, do you code 10 not applicable due to environmental limitations, i.e. lack of equipment for dressing? So if a patient does not have clothing, then we have a couple of scenarios that we can go through. So the intent for this item is to assess the patient's dressing ability with clothing that would be worn in the community. If clothing is available by day 3, you would code based on the assessment conducted on that day. So if the patient doesn't have clothing on day 1, but they get it on day 2 or day 3, you can code it then. If clothing is not available by day 3, paper scrubs could be used to assess the activities of upper and lower body dressing if no other clothing is available. And if a patient does not have upper body clothing other than a hospital gown during the entire 3-day assessment period, in this scenario, you would use code 10, not attempted due to environmental limitations for GG0130F upper body dressing. So coding based on a gown is not, a gown only, I should say, is not allowed because it would not represent what the patient's abilities are for dressing with the clothes that would be normally worn in the community. And reports from the patient and family could not be used alone when coding this item. The reports of the family should be incorporated along with observation. So the goal for this item is to assess the patient's current abilities. And if a patient was dressing differently before they got to the hospital than how they were when this item was assessed, that needs to be taken into consideration. Okay, so next we have GG0130H, putting on and taking off footwear. This is defined as the ability to put on and take off socks and shoes or other footwear that is appropriate for safe mobility, including fasteners if applicable. So again, we have some examples of footwear items. For this item, you would assess the patient based on the footwear that the patient routinely wears. And again, this is not an exhaustive list of footwear items. So our practice coding scenario for GG0130H, putting on, taking off footwear. Mr. Q underwent bilateral below-the-knee amputation 3 years ago. He uses bilateral limb prosthesis with attached shoes and socks that he never changes. Prior to the current episode of care at the acute care hospital and during his IRF stay, he does not perform the activity of putting on and taking off footwear. So based on this information, how would you code GG0130H? Your options are A, 01 dependent, B, 09 not applicable, C, 88 not attempted due to medical condition or safety concerns, or D, 07 patient refused. Great, and we'll take a look at the correct answer now. And it is, 09 not applicable. The rationale for this is that patients with bilateral lower extremity amputations with or without use of prosthesis, the activity of putting on and taking off footwear may not occur. Mr. Q's socks and shoes were attached to his prosthesis, as I told you guys, so Mr. Q did not perform putting on and taking off footwear prior to the current illness, exacerbation, or injury, and the activity was not performed during the assessment period. And just a quick note here, if a patient has recent bilateral leg amputations and completes putting on and taking off footwear immediately prior to the current illness, exacerbation, or injury, then here the applicable code would be 88, not attempted due to medical condition or safety concerns. Okay, so now we'll go through the self-care discharge goal columns quickly. So this is what it looks like again on the item set. You have the admission performance on the left-hand side and the self-care discharge goal on the right. Some coding tips for discharge goal. You would code the patient's discharge goals using the 6-point scale that we went through at the beginning that you guys saw at the decision tree and that I'm sure you all are very familiar with, or one of the activity not attempted codes, that is 07, 09, 10, or 88. This is updated guidance, of course, effective October of last year. For the IRF QRP, at least one goal must be indicated for either self-care or mobility. And you can use a dash to indicate that a specific activity is not a goal. Using the dash in this allowed instance does not affect APU determination. So licensed clinicians can establish a patient's discharge goals at the time of admission based on the following: patient's prior medical conditions, prior and current self-care mobility status, discussions with patients and family members concerning their discharge goals, the professional standard of practice, expected treatments that the patient should be undergoing in the IRF, patient motivation to improve, and anticipated length of stay. And goals should be co-created and established as a part of the patient's care plan. Finishing up on discharge goal coding tips. They may be coded the same as admission performance, higher than the admission performance, or lower than the admission performance. And if the admission performance of an activity was coded using one of the activity not attempted codes, so 07, 09, 10, or 88, a discharge goal may be submitted using the 6-point scale if the patient is expected to be able to perform the activity by discharge. So let's say a patient came in, they weren't able to do an activity, but after coming to your IRF and going through the treatments, they were able to. You can use that 6-point scale. And I know I mentioned this, although it's not typical for IRF patients for the discharge goal to be lower than the admission performance, it can be the case in some cases. And so again, I'm going to turn over to Anne, who's going to take over and go through GG0170 mobility at this time. Thank you all.
Great, thank you so much. Does anyone want to stand up and stretch or put their arms up? We're going to be covering the section GG mobility section next, so we have quite a few more slides, but feel free to stand up, or then those who are online, welcome to do that too. So. All right, so moving on to the mobility section. So we'll be similar to what Manisha did. We'll be covering the item definitions because, as Manisha mentioned, that's really important. That'll definitely help you in terms of thinking about coding. And then we'll go through a few coding tips, throw in some Q&As that we've gotten that we think will be helpful to cover. And then we'll go through some Slido questions and go over the answers. So in the area of mobility, as you are aware, there are quite a few mobility activities covering things like bed mobility, transfers, walking, stairs, and picking up an object. Similar to what you saw on the self-care area, on the admission assessment, you will see 2 columns, the first being admission performance, the second column being a discharge goal. On this slide, we have the walking items, the stairs items, also the wheelchair items. And as you may know, for the wheelchair items, there's a gateway question. So we'll talk a little bit about skip patterns related to that gateway question. And then for the wheelchair items, there's also follow-up questions related to the type of wheelchair. So starting off with the bed mobility items. So the first activity is rolling left and right, and this refers to the ability to roll from lying to the back and left and right side and returning to the back on the person's bed. One of the questions that we get about this particular topic that's fairly common these days, both from the inpatient rehab facility providers as well as skilled nursing facility, what if somebody doesn't sleep on a bed? So if somebody uses an alternative sleeping surface, please assess them on that alternative sleeping surface. So if they sleep on a mattress on the floor, or whatever they sleep on can be done for the assessment for the bed mobility items that talk about a bed. So another topic that we get questions about is if the person cannot lay flat in the bed, how do you code bed mobility activities where you talk about lying on a bed? So if the clinician determines that bed mobility cannot be assessed because the degree to which the head of the bed must be elevated due to a recent onset medical condition, you would code the bed mobility activities including GG0170A, roll left and right, GG0170B, sit to lying, and GG0170C, lying to sit on side the bed, as 88 not attempted due to medical condition or safety concern. If the person has a long-standing condition where they've not been able to lie flat for a long time, and so that meets the criteria of Code 9 that Manisha covered. So Code 9, just as a reminder, means the activity did not occur at the time of the assessment, and the patient was not able to do that activity prior to the current illness, exacerbation, or injury. So the difference between Code 88 and 09 is that for Code 88, in addition to the, so for Code 88, the activity didn't occur at the time of assessment, so admission or discharge, but the person did do that activity prior to the current illness, exacerbation, or injury. For Code 9, it means the person did not perform the activity prior to the current illness, exacerbation, or injury. So the example here, we coded at 88 because we talked about it being a recent onset condition. So I hope that makes sense. Okay, so for GG0170A through C, those bed mobility activities, you would use clinical judgment to determine what is considered a lying position. So, for example, the clinician would determine that a patient's preferred slightly elevated resting position is considered lying, and that's adequate. So you'd be using your clinical judgment if you can do the assessment. If the head of the bed is elevated so high that you don't really feel the person is lying flat, you may make the judgment that the activity would be coded one of the activity not attempted codes. So we do have another practice scenario, and just a reminder again, you do have all of these examples in your packet. So this is, material number 5, and we're on scenario 9, so that's actually on page 7 of that packet. It started off with DRR, it has the self-care activities, and now we're moving to the mobility activities. So if you wanted to follow along here, you can do that. The other thing that I want to encourage you to do is look at the decision tree, and I'll actually use it as part of going through scenarios to help you to see how it can be helpful for you. So in this particular example, we have Ms. W. So Ms. W's head of the bed must remain slightly elevated at all times due to aspiration precautions. So maybe she had a stroke. Although the head of the bed is slightly elevated, the therapist determines that she can assess Ms. W's ability to roll left and right. The therapist provides verbal instructions as Ms. W completes the activity. So if you were new to this and were trying to figure out how to code it, you would look at the decision tree and say, okay, the first question basically asks whether the patient was able to complete the activity with or without assistive devices by him or herself with no physical or verbal or cueing assistance or setup. So does that apply here? No, she did need some help. So then we would go down to the next question on the decision tree. Does the patient need only setup, cleanup assistance from one helper? Or she needs more? She needs more, yes. So we go down to the next question, which basically says, does the patient need only verbal, nonverbal cueing or steadying touching assistance or contact guard assistance from one helper? What do you think? Are we there? Okay. All right, so now you can help me with the answer here. So would you code Ms. W as 05, setup or cleanup assistance, 04, supervision or touching assistance, or 9, not applicable, or 88, not attempted due to medical condition or safety concern? Okay, I'll wait for a few more people to answer. Okay, we'll wait till it gets to 100. Okay, great. So most people coded 4. I do agree with that. That is indeed the right answer. So as you correctly indicated, Ms. W requires verbal instructions while rolling left and right in bed, and the assessment definition includes lying on the back. In this example, the clinician used clinical judgment to determine that the assessment can be conducted with the head of the bed slightly elevated. The next activity, again, another bed mobility activity, is sit to lying. For sit to lying, the definition is the ability to move from sitting on the side of the bed to lying flat on the bed. So for the practice scenario here, this is number 10, we have Mr. P. So Mr. P has peripheral vascular disease and recently had a right above the knee amputation. Mr. P requires a physical therapist to provide steadying assistance as he moves from a sitting position to lying down. How would you code Mr. P? So again, if we were going through the decision tree, does Mr. P need help? Yes or no? Yes. So he's not able to do it independently, so we go down on the decision tree. Does he require only setup, cleanup assistance? Okay, so we go down further in the decision tree. Does he only need verbal cueing, steadying, touching assistance, contact guard assistance from one helper? Yes, okay. So go ahead and put your answers in. The options that you have for answers on Slido are 05, setup or cleanup assistance, 04, supervision touching assistance, 3, partial moderate assistance, 09, not applicable. Okay, I'll wait for a few more responses. Okay, great. So it looks like most of you are coding 04. I do agree with that, and that is indeed the right response. So as you correctly indicated, the helper provides only steadying assistance as Mr. P performed the activity. The next activity that we're going to cover is lying to sit on the side of the bed. And for this activity, it refers to the ability to move from lying on the back to sitting on the side of the bed with feet flat on the floor and with no back support. So we do have a video scenario here.
Hi, Mrs. Brown. How are you today?
I'm doing a little better, thanks.
Good. Can you come sit on the side of the bed for me?
It's hard, but I'll try. Oh, could you help with my legs?
Of course. Good job.
Thank you.
Okay, so, oops, sorry. So let's see, we do have a coding scenario here. So in this case, this was an example of a code 3, and the rationale for this answer is that Ms. Brown began to move to a seated position, and the clinician assisted with pivoting Ms. Brown's legs to the side of the bed. So again, the level 4, as Manisha covered, is about touching, steadying assistance, perhaps some verbal, but once you provide lifting assistance, the code will be level 3 or below. So in this case, if you were the clinician helping the patient, you'd be probably in a much better position to judge the amount of effort, but overall the judgment was that the patient did more than half of the effort, the helper did less than half of the effort, and so that would be coded 03. So again, Ms. Brown began to move to a seated position, and the clinician helped move both of her legs. The clinician provided assistance that represents less than half of the effort. Okay, so we do have a bit more video here.
Hi, Mrs. Brown. How are you today?
I'm doing a little better, thanks.
Good. Can you come sit on the side of the bed for me?
It's hard, but I'll try.
Looks like you're struggling a bit. Can I help you?
Yes, thanks.
Okay, first, let me have you try to lie on your side. Great. Now, put your hand on the bed and push yourself up. As you do that, I'm going to put my hand on your upper back and arm and swing your legs until you're in a seated position. Is that okay?
Sure, let's give it a try.
Good job.
Thanks.
Okay, so in this video, there was a little bit more assistance being provided, and so I will let you consider what you saw and the assistance being provided. The options are 04, supervision, touching assistance, O3, partial moderate assistance, O2, substantial maximal assistance, and O1, dependent. Okay, I'll wait for a few more. I think sometimes the online takes a little bit longer, so I want to be sure they get to see the answers and put their select the answer. Okay, looks like most people coded O2, and I do agree with that response, and that is the correct response. So in this instance, Mrs. Brown required the clinician to provide lifting and physical assistance that represents more than half of the effort to complete the activity, and moving from lying on her back to sitting on the side of the bed. So, in this scenario, you had the same patient demonstrate two different levels. So you saw the level 3 where it was assisting with the legs, and in this second instance, she needed more help to even get to the sitting position. So moving to the transfer items next. So the first item in this area, first activity, is sit to stand. So this refers to the ability to come to a standing position from sitting in a chair, wheelchair, or on the side of the bed. So however it's assessed, it's acceptable to do any or all of those. So we have scenario 12 here, where Ms. P is morbidly obese and has severe arthritis in both knees. She is unable to transition from sit to stand without the use of a mechanical lift. Ms. P lifts and places her feet on the standing lift device to initiate the activity. Assistance from 2 helpers is required as Ms. P is helped to transition from a sitting to a standing position. So let's walk through the decision tree on this one. So the first question asks, if the person was able to do the activity without help. Clearly, she needs help. So the next question down, did she need just setup assistance? No. Did she need just steadying verbal cueing? Okay, so, and by the way, one of the things you'll notice on the decision tree that I want to be clear to point out is that the decision tree talks about one helper. So was it set up from one helper? Was it steadying cueing from one helper? So then the next question is, does the patient resident need physical assistance? For example, lifting or trunk support from one helper, with the helper providing less than half of the effort. Okay, and then does the helper need physical assistance? Could be trunk support or lifting from one helper, with the one helper providing more than half of the effort. So it doesn't meet that criteria. And so basically the last question at the bottom of the decision tree here is, does the helper provide all of the effort to complete the activity, or is the assistance of 2 or more helpers required to complete the activity? So based on your reading the example, I will let you pick the answer that you think is the correct response. The options are code 2, substantial maximal assistance, code 1, dependent, 09, not applicable, 88, not attempted due to a medical condition or safety concern. I'll just wait for a few more responses to come in. Okay, so you are indeed correct. Code 1 is the correct response. And the rationale is that although Ms. P placed her feet on the mechanical lift without assistance, getting from a sitting to a standing position required the assistance of 2 helpers. If the assistance of 2 or more helpers is required, you would code 01. And just to clarify, because we have had this question come in through the help desk, so basically, when you are coding level 1 because 2 or more helpers are required, it's because the patient requires the assistance of 2 helpers, not that maybe, 2 people happened to be there and both ended up helping. I think one of the important things that's, for coding just the GG items overall, these activities should be assessed. It's a clinical assessment, and so you should be allowing the person to perform the activity as independently as possible. Obviously, safety is a concern, so if you are very concerned about the person's safety during a transfer or walking. If the patient requires the assistance of 2 or more people because of safety, absolutely, that's a level 1. But again, please allow the person to do the activity as independently as possible. And when an activity might occur, and certainly when I was a nurse and patients had to get off to therapy on time and, it was time to hurry up and get dressed, there were instances where I helped patients more than they maybe needed to. In that instance, that's not a clinical assessment. So that instance of dressing doesn't count. So again, just pay attention to this idea that this is a clinical assessment, allowing the person to perform the activity as independently as possible. I think another question that comes up that this makes me think about this answer is for the coding, as Manisha covered, the code 1 refers to the person requiring the helper performs all of the activity in order for the activity to occur. So if the patient participates a little bit in performing an activity, the code goes up to 2. But if you follow the decision tree, and this question came up in, I think, the May training, in the instance that you have 2 or more helpers and the person helps a little bit, if you follow the decision tree will help you come to the determination that the code would be 1. So basically, in the instance where the person is participating a little bit and the assistance of 2 or more helpers is required, the 2 or more helpers required kind of becomes the key issue, and the code would be a 1. If you only have 1 helper, so if we had, let's say, this example where it was 1 helper and she was helping a little bit and was participating to perform the activity a little bit, she would get credit for that. Mrs. P would get credit for that, and her code would be a 2. So I hope that clarifies something. I think I might have seen something on the Slido about that. Okay, so the next activity is bed to chair transfer, and this refers to the ability to transfer to and from a bed or wheelchair. If somebody uses a slide board to transfer, maybe somebody who had a spinal cord injury or somebody has below the knee amputation, so a transfer board certainly is an acceptable way to do this particular activity. I do want to highlight that the activities of sit to lying and lying to sit, which we previously covered, are 2 separate activities that are not assessed as part of GGO 170E. So the activity of transferring from the bed to the chair to bed, begins with somebody in the sitting position. And when the person is getting out of bed, if the person is getting back into bed, they would actually end the activity sitting upright on the side of the bed. If a mechanical lift is used to assist in transferring a patient for the bed to chair transfer, and 2 helpers are required to assist the patient needs the assistance of 2 helpers, and they're using a mechanical lift, then the code would be 01 dependent if the patient assists with any part of the bed to chair transfer. And again, the rationale is that if you follow the decision tree, if 2 or more helpers are required, you're always going to end up at that level 1, because all of the questions prior to that refer to 1 helper, 1 helper, 1 helper. The next coding scenario we have is obviously bed to chair transfer. So this is scenario number 13. So here we have Mr. L. He has spinal stenosis and due to back pain does not fully stand up. He uses a stand pivot style type of transfer to get from the chair to the bed and from the bed to the chair. And this occurs obviously during the 3-day assessment period. The occupational therapist uses a gait belt around Mr. L's waist, providing initial lifting assistance from the chair bed as he raises himself to a stooped over position. The therapist continues to steady him as he completes a pivot, turns, and then lowers himself into a chair. Mr. L contributes more than half of the effort. So if we were going through the decision tree, does he need help? Yes. Is it more than just setup assistance? Yes. Is it more than steadying assistance? Okay, and so we're down to either a 3, 2, or a 1, and so again, you'll be making a determination about, does the helper provide less than half of the effort, more than half of the effort, or all of the effort? The options that you have on Slido are 04, supervision touching assistance, 03, partial moderate assistance, 02, substantial maximal assistance, 01, dependent. Okay, it looks like most people are heading towards 3. I see a couple of 2s. For the decision tree, you'll notice that level 3, the helper is doing less than half of the effort, the patient is doing more than half of the effort. At level 2, the helper is doing more effort than the patient. And in this instance, I believe it said that Mr. L was doing more than half of the effort. So it looks like we're at 97 people who've submitted answer 3. And the correct response, I do agree with what you've put, 03. Partial moderate assistance. So the rationale here is Mr. L requires a helper to initially provide lifting assistance during the transfer, so that's more than touching assistance, and the helper provides less than half of the effort. It is acceptable if the patient is only able to partially rise, then pivot, turn, and sit on the chair, bed, or wheelchair. So again, can be a slide board transfer, could be a stand pivot, could be, this partial kind of standing and pivot. The next activity is toilet transfer. So this is very simply getting on and off a toilet or commode. So it could be a bedside commode right next to the bed, or the person may be going to the toilet. As Manisha highlighted in the self-care activities, getting to and from the bathroom is not considered encoding. It's basically just transferring on and off the toilet or the commode. One of the things I do want to highlight is that the toileting hygiene item that you heard about earlier today includes activities that obviously happen around the toilet transfer, but when you're coding the activity, do pay attention to the definitions. So the toileting hygiene, just as a reminder, relates to the person managing clothing. So for most people, it's going to be pants down, wiping, pants back up. The toilet transfer is going to happen in between that, but do, again, keep those definitions in mind. It's absolutely possible that somebody, for example, may be holding onto a grab bar as they're pulling their pants down and as they sit down onto a toilet. And so basically that grab bar, or maybe you're providing steadying assistance while both the toileting hygiene and the toilet transfer happens and you're just holding onto them continuously. But steadying assistance was required in that example I just made up at the time of coding toileting hygiene, as well as the toilet transfer. We also have had questions about whether a bedpan counts. The answer is no. Transferring on and off a bedpan is not considered when you're doing toileting transfer. So if the person, if the patient is not getting on and off a toilet, not getting on and off a commode, only use a bedpan, you would use the appropriate activity not attempted code, but hopefully that's pretty rare. Just a reminder that the activity not attempted codes would indicate that the activity did not occur during the entire 3-day assessment period. I think there might be some rare exceptions, but if I saw a code of 88 or 09 or 07 for toilet transfer, I'm going to, when I look at the data and run analyses, I'm going to think, this person did not get on and off a toilet during the first 3 days of admission or during the last 3 days of the stay. So please be very careful about the coding of the activity not attempted codes. I wouldn't expect a code 10 on this one. That's another thing. The code 10, as you may know, was added And that should mainly probably be used for things like car transfers, uneven surface. But if I saw a toilet transfer, code 10, I would wonder if that meant you didn't have a toilet available. I'm not sure what that would mean. But anyway, please do pay attention to those things. The activity attempted codes should not be used a lot on some of these activities that are, especially the self-care activities. These are things that patients would be performing, especially over a 3-day assessment period. So I think Manisha even brought up the issue of, somebody not have clothing. Well, if somebody had clothing on day 3, code it based on day 3. So I think she emphasized, think about that whole 3-day assessment period. Okay, so the next activity is toilet transfer. So here, Ms. M had a total hip replacement following a hip fracture and was in an acute care hospital prior to being transferred into an inpatient rehabilitation hospital. While in the acute care hospital, she used a raised toilet seat. When Ms. M needs to void, the certified nursing assistants provide steadying assistance as Ms. M transfers safely from the wheelchair onto the raised toilet seat. So I will let you think through the decision tree on this one. And again, if you want to look at the handout to look at the example a little bit more, the options for coding this activity are 05, setup cleanup assistance, 04, supervision or touching assistance, 03, partial moderate assistance, 09, not applicable. All right, a few more answers. Okay, looks like most people coded, well, it looks like actually everybody coded 04. Awesome. I agree with you on that one. Oh, somebody put in a other one answer. Okay. All right. Most of you coded 04, supervision, touching assistance. So indeed, that is the correct response. The certified nursing assistance provides only steadying assistance during the activity. The raised toilet seat is used during the initial assessment and was previously used in the acute care hospital. I do want to highlight, because we do get a lot of questions about this, are patients allowed to be assessed on the admission assessment with a new device? The answer is yes. So if somebody, let's say, let's say theoretically this woman had not used a raised toilet seat prior, maybe she used a bedpan, I guess, in acute care, and so she's brought over to the rehab unit. You want to, make sure she's using the toilet and all that, and so a raised toilet seat is used. You can assess her with that raised toilet seat, code based on the type and amount of assistance required. If it's a new device you might be providing, maybe more steadying assistance, and you can definitely code based on that initial assessment. Okay, the next activity is car transfers. So car transfers refers to the ability to transfer in and out of a car or van on the passenger side. It does not include the ability to open and close the door or the ability to fasten the seatbelt. We've also had questions recently about getting to and from the car. That's not considered. Again, it's just really once the person is close to the car or the car simulator and the person's ability to get into the car on the passenger side and to exit the car on the passenger side. So we do have a fair number of coding tips in the manual related to car transfers, so I just wanted to go over some of those. So use of an indoor car can be used to simulate outdoor car transfers. These half or full cars would need to have similar features of a real car. I know some people have Easy Street or different options. You'll be using your clinical judgment if you don't have an actual car to practice with or a partial car available. We get all kinds of questions about whether a golf cart can count or this or that. Please use your judgment. The idea is that especially at discharge, somebody should be able to transfer in and out of the car safely at discharge. And I will tell you, we have had questions on help desk where, instances where they said, the patient was being discharged with a family member, was transferring into the car and fell. and ended up in the emergency room. So the question came in asking, what's the discharge destination? Because in this case, the person ended up going to the emergency department. But it just is a reinforcement of how important it is to make sure that something like car transfer is being assessed for patients before they're discharged. It's something we do all the time, getting in and out of cars. And it's, kind of hard after maybe a stroke or spinal cord injury. Car transfers do not include transfers to the driver's seat, opening, closing the car door, or fastening or unfastening the seat belt. Please use your clinical judgment again about what simulation can be done. In the event of inclement weather, so perhaps you have an outdoor parking lot, and you usually would take somebody to practice car transfers outside, maybe when the family's visiting, and maybe like me, you live in Chicago and it gets cold. It was like -50 one day last year. And so you would not do it on that day probably. And so if you're not able to practice a car transfer because it was a cold spell for a week and the person was being discharged, so you could code the Code 10, not attempted due to environmental limitations in those instances when you only have access to outside parking lot, and you didn't have, let's say, a simulator inside your facility. But in general, if there is an ability to transfer in and out of a car when family's visiting, or you have, a car available to transfer in your garage, please do try and do those assessments. Okay, so we do have a practice scenario here. This is number 15. So this is when performing car transfers, Mr. T, who recently had hip surgery, requires significant support from the physical therapist as he transitions into the passenger seat of the car to maintain his hip precautions. Once seated, Mr. T places his left leg in the car and requires assistance to lift his his right leg into the car. So the helper is lifting a leg. So think about the decision tree. When transferring out of the car, Mr. T requires significant physical lifting assistance from the therapist, and the therapist lifts his right leg out of the car. Mr. T lifts his left leg out of the car. So as you're thinking through the decision tree, let's look at that last bullet there. So he's transferring out of the car. The helper is providing significant lifting assistance, so think about who's probably doing more of the effort there. And the therapist lifts the right leg out, but an important part here is the last part. Mr. T lifts his left leg out of the car, so he is contributing effort, and so that's really important as you think through the decision tree, because as I mentioned before, Code 1 means that the helper did all of the effort. So I will let you think through the decision tree and let you put in an answer here. So the options are Code 5, setup or cleanup assistance, 04, supervision touching assistance, 3, partial moderate assistance, 02, substantial maximal assistance. Okay, we're getting close to 100. Yeah, we're at 100. Okay, so it looks like most of you coded 02. I do agree with that answer. And let's see what the correct response is. It is indeed a 2. So here the rationale is that the helper provides more than half of the effort, but Mr. T did contribute by lifting his leg in, and so he does get credit for contributing to the effort. Okay, so next we're moving to the walking items, and we're going to start off with the walk 10 feet. So the definition of walk 10 feet refers to, once standing, the ability to walk at least 10 feet in a room, corridor, or similar space. One of the things that I do want to highlight is that if admission performance is coded, one of the activity not attempted codes, so that's 07, 09, or 88, you will actually skip over the next few items. The assumption is that if the patient cannot walk 10 feet, that the patient would not be walking 50 feet with 2 turns or 150 feet. So in your system, it's probably grayed out. You won't be able to enter anything. So again, just reinforcement. So if the patient is unable to walk the 10 feet, you would skip to the one-step curb. We do the skip does go to the one-step or curb because it's possible somebody's in a wheelchair, so they are not walking 10 feet, but they are able to go up one step or the curb in their wheelchair. And so that's why it's skipping you to the step, because it is possible somebody is not walking, but they're able to go up and down that one step. So the little Post-it note on the slide is, again, if the admission performance of the activity was coded using one of the activity not attempted codes, so, it triggers the skip pattern for the performance, but you may still code a goal for that activity. So perhaps on admission, the person is not able to walk 10 feet. Maybe they walk 8 feet, but by discharge, they will be able to accomplish walking 10 feet. Then you would actually be able to enter a goal if that's your, if that's something that you wanted to code as a goal. When assessing the patient for the walking items, do not consider walking in parallel bars. And part of the rationale is that parallel bars are not portable, so if the person's in their bedroom and they need to go to the bathroom, it's not like they can use the parallel bars to get to the bathroom. So in general, as Manisha kind of indicated before, CMS doesn't provide an exhaustive or comprehensive list of devices that do or don't count, but in general, devices that would be used in therapy and only therapy and can't be used outside of therapy. So parallel bars is one example. You would not consider those. And so if the person was only able to walk in parallel bars during therapy and, when they were in their room needing to go to the bathroom or, go to the sink to brush your teeth, you may be coding the one of the activity not attempted codes if that's true for the entire 3-day assessment period. So we have an example: if the patient cannot walk without the use of parallel bars due to a recent onset condition, you would code 88. Obviously, as I described before, if somebody had a long-standing, perhaps somebody had a spinal cord injury 20 years ago, and so the person is not able to walk 10 feet. We're not able to do it prior to the current illness, exacerbation, or injury, so maybe they're admitted with a new condition, but the person was not able to walk 10 feet prior to the current illness, exacerbation, or injury. It would be coded 09. That would be the appropriate activity not attempted code for that patient. We have had questions in the past about whether a patient is allowed to take a break when walking, and so you would be using your clinical judgment, but in general, CMS has said that a patient may take a standing brief break, a breather, if you will, while walking any of the distances. This question mostly comes up with 150 feet, but a breather is allowed. And I guess the other issue about this is that we mentioned standing. Somebody cannot walk part of a distance, sit down, and walk the rest of the distance. That wouldn't count. Actually, we did the sniff training the last couple of days, and somebody asked if somebody can take a breather break during wheelchair, traveling wheelchair, self-mobilizing 150 feet. The answer is yes. A breather is okay, but you'd be using your clinical judgment about how long the person could actually take that break for. So again, clinical judgment. So we have practice case scenario 16 here for walk 10 feet. Mr. S has an open reduction internal fixation on his left lower leg after a fall, so it's a recent onset condition, and is non-weight bearing on his left lower extremity. Mr. S walks 10 feet in the parallel bars with the physical therapist, providing more than half of the effort to support his trunk. So how would you code this example? The options are 01, dependent, 02, substantial maximal assistance, 3, partial moderate assistance, or 88, not attempted due to medical condition or safety concern. Okay, so what was the key thing that most of you are coding 88? Parallel bars, thank you. All right, you can change your answers. I know there was a bit of a distractor there that, more than half of the effort, but the bottom line is it was parallel bars. You're exactly right. And so the correct response is indeed 88. And again, parallel bars. Okay, the next activity is walking. So walking 50 feet with 2 turns. Again, this is going to begin with the person standing, and it refers to the ability to go 50 feet and make 2 turns. Common question we get about this activity is, what is a turn? So CMS has determined a turn for this particular activity refers to 90-degree turns. The turns can occur in the same direction, so 2 left turns or 2 right turns, or it could be that the person is able to turn once to the left and once to the right. The 90-degree turn should occur at the person's ability level and can include the use of an assistive device if appropriate for that individual, so a cane or a walker, without affecting the code. So I think Manisha covered this earlier, that you would code patients on an activity with or without assistive devices, whatever is appropriate for that individual. So we do have a coding scenario here also. Mr. R has chronic neurologic condition and has poor balance as a result of that. He has used a walker for many years. He ambulates 50 feet with 2 90-degree turns, requiring contact guard when he makes 2 turns. How would you code Mr. R for 50 feet walking with 2 turns? The options are 05, setup or cleanup assistance, 04, supervision touching assistance, 03, partial moderate assistance, or 09, not applicable. Okay, wait for a few more answers. When you're thinking about turns, of course, somebody who is wheeling down a hallway and then goes into their room, they're making a turn. Or if somebody is wheeling in their room and they turn to a bathroom, they're making a turn. So, or walking. So definitely, as you're thinking about the walking and the wheelchair items, those turns are definitely things that happen. Actually, if you look at research where they've tracked people turn a lot every day, all the time. So you should be able to be able to assess this, because turns are something we do all the time. Okay, so it looks like 04, I do agree with that response, and that is the correct response. So again, the rationale was contact guard assistance is 04. The last walking item here is walk 150 feet. So again, starting once in a standing position, the ability to walk 150 feet in a corridor or similar space. We do get questions, by the way, in relation to these walking items. Can you basically assess them simultaneously? So I think our only caution is that with the 50 feet with 2 turns, you've got the turn in there. There's no turn with the 150 feet. So just pay attention, again, to the definitions. But let's say you have somebody who is independent. Let's say this person had an excellent rehab program, is independent, walking 150 feet by discharge. You can certainly determine, using your clinical judgment, the 10 feet was also independent or with supervision or touching assistance. But again, use your judgment in terms of overlapping or sequential coding related to walking. We've also had the question about whether these activities all need to be assessed during the same therapy session, and the answer is no. They can be assessed together, but they do not need to be, so you can assess perhaps 10 feet, during one therapy session and maybe a longer distance the next day. So we have another practice scenario here. Ms. T walks with her walker 150 feet independently as long as she takes very brief standing rest breaks halfway through the walk. How would you code Mrs. T? Your options are that she is 6, independent, 5, she requires setup or cleanup assistance, 04, supervision or touching assistance, or 09, the item is not applicable for this individual. All right, somebody coded 09. Did you press the wrong button? Okay, most of you coded independent, and that is correct. That person's online? Okay. All right, so I agree the correct response is 6, and again, you're allowed to take a breather break, and it was standing, so it's totally appropriate to code that as independent. Okay, so the next activity is walking 10 feet on uneven surfaces. For this particular activity, it refers to the ability to walk 10 feet on an uneven or sloping surface. It could be indoor or outdoor. Examples that we have in the manual are things like turf or gravel. So in some instances, I know facilities may have an outside garden. They can take somebody walking on grass. I know some IRFs have set up obstacle courses, and they have people walk through the obstacle course a little bit. Those are all appropriate. Again, you'd be using your clinical judgment. I know we sometimes get questions about whether going from, let's say, a wood floor to carpet counts. That could be part of it, but that probably doesn't last 10 feet. So, it is a 10 feet distance. So we have another practice scenario here, number 19. So Mr. B, I think Manisha had a few Mr. Bs. So Mr. B sustained an incomplete spinal cord injury after a car accident. He ambulates outside on grass and negotiates a turf, with the therapist providing more than half of the effort to support his trunk. How would you code Mr. B? The options that you have on Slido are 05, supervision cleanup assistance, 04, supervision or touching assistance, 3, partial moderate assistance, or 02, substantial maximal assistance. Okay, looks like most people are coding 02. We've got one person who coded 04, but otherwise 02. I think 02 sounds right to me. Let's see what the correct response is. 02, that's right. The therapist provides more than half of the effort in order for the patient to ambulate 10 feet on an uneven surface. Again, it could also be a sloping surface if you looked at the definition. So now we're moving to the stairs activities and pick up object. So the step, it refers to the ability to go up and down a curb or up and down one step. There is a skip pattern here. Again, the logic being that if an individual is not able to go up and down one step, the person probably is not able to manage going up and down 4 steps or 12 steps. So the skip pattern actually is to go to pick up object GG0170P. As I mentioned before, somebody can certainly go up and down in a wheelchair. I think we've also had questions about somebody going up and down on their behind. Totally fine. The wording is that the person goes up and down. It's not the person steps up and down, so it is truly going up and down. If the admission assessment, so on the little sticky note, there's a coding tip here. If the admission performance of the activity was coded one of the activity not attempted codes, 07, 88, 09, or 10, the discharge goal may be submitted using the 6-point rating scale. So again, the skip relates to the actual performance column. You may still enter a goal. We have another practice coding scenario here. So we have Mrs. A. She has ataxia due to a neurologic condition. She uses a quad cane while walking. While stepping down an outdoor curb, Miss A steps down with the physical therapist, providing significant trunk support to help Miss A maintain her balance. When stepping up the curb, Miss A requires a significant amount of trunk support from the therapist. Miss A contributes effort. The helper provides more than half of the effort. So again, if you think through the decision tree, you'll probably end up near the end there, and you'll have to think through who's providing more than half of the effort and whether the patient contributes any effort. So that last bullet obviously is important. The options for the answers here are 04, supervision touching assistance, 03, partial moderate assistance, 02, substantial maximal assistance, 01, dependent. Looks like most people are coding 02. That seems right to me, so let's see what the correct response is. Okay, it is indeed O2. Miss A requires a helper to provide significant trunk support while Miss A steps down the curb. The same amount of assistance is required as Miss A steps up the curb, resulting in the helper providing more than half of the effort. Going up and down a curb does not have to occur back to back, but both are considered when coding this activity. The next activity is 4 steps. So again, going up and down 4 steps. Somebody may certainly use a railing if that's available, or an assistive device, or both a railing and an assistive device. Again, similar to the skip pattern related to 1 step. If somebody's not able to go up and down 4 steps, we believe they probably are not able to go up and down 12 steps, so you will skip over that one 12-step activity. You may still enter a goal for 4 steps, even if that 4 steps item gets coded one of the activity not attempted codes. The practice scenario here, Mr. F is recovering from multiple lower extremity fractures and wears a walking boot and uses a quad cane. Mr. F slowly ascends the stairs, grasping the stair railing with one hand and his quad cane on the other hand. The therapist provides intermittent steadying assistance as he climbs up the 4 steps. He then turns around and requires steadying assistance throughout the activity as he goes up and down 4 steps. So I'll let you code this. The options are O5, setup or cleanup assistance, O4, supervision touching assistance, O3, partial moderate assistance, O2, substantial maximal assistance. All right, looks like most people. Okay, now everybody's coded O4, and I do agree with that. One thing I would like to highlight about the steadying assistance that's brought up in this example is that going up the stairs, it was intermittent steadying assistance, intermittent steadying assistance. On the way back, it was steadying assistance throughout, either throughout an activity, or if there's intermittent steadying, either of those scenarios would be coded O4. So in this case, it didn't make a difference. Both were O4. So rationale here, Mr. F requires steadying assistance intermittently going upstairs and throughout going down the stairs. If steadying assistance is intermittent or throughout the activity, the code would be O4. He does not require weight bearing or lifting assistance, and that's why it wasn't coded a lower level. For 12 steps, obviously going up and down 12 steps is the activity. The scenario here is Mr. B. He's receiving rehabilitation following a hip fracture, or Miss B, sorry. And her home has 12 steps from the entry level to the second floor. During the discharge assessment, Mrs. B uses a cane and a stair railing to ascend 12 steps. She goes one at a time. The physical therapist provides contact guard assistance following behind Mrs. B. When Mrs. B descends the stairs, the therapist provides contact guard assistance and holds Ms. B's gait belt to steady her. How would you code this activity? Your options are 5, setup or cleanup assistance, 4, supervision touching assistance, 3, partial moderate assistance, 2, substantial maximal assistance. Okay, it looks like most people would code O4. Let's see what the correct response is. It is indeed code 4, the rationale being that she requires contact guard assistance, which is considered touching assistance. She does not require weight-bearing lifting assistance. So we do get some questions about stairs on a regular basis, so this is just an example of one of the ones actually from the May training. If a patient cannot complete an activity because he or she states that he or she is simply tired, fatigued, or exhausted, should we code this as a refusal or 88 safety or safety concern? For example, a patient completes 8 out of 12 steps and then says he or she is done. So you've probably heard that, right? So we would say in that instance, please use your clinical judgment. Obviously, after somebody's experienced a stroke or a brain injury, or maybe somebody with a neurologic condition like MS, fatigue is a significant issue for those patients. And so if it's your determination or the patient expresses that there is a safety concern or that, they are fatigued, you may certainly use your judgment to say that this is an 88, activity not attempted code. If in the instance you believe that the patient is refusing to perform the activity and there's really no underlying medical or safety issue, you may code 07, but my guess is most of the instances there's probably a legitimate underlying issue going on, and you may certainly code that an 88 or perhaps even probably an 88 would be most instances. If the patient completes the activity once during the assessment period, code based on the amount of assistance provided. One of the things that I do want to be sure to highlight, because we have had questions about this recently and some discussions, for activities like walking and stairs. So let me start actually with walking. So if a patient is able to walk, let's say, 100 feet, but not 150 feet. If I'm the helper, I'm not in a position to actually walk the remaining distance for the patient. And so in the instance where the activity cannot be completed, so let's say the person can only walk 100 feet, we would say the activity was not attempted, or one of the activity not attempted codes would be used because the activity wasn't completed. And so if an activity wasn't completed, I'm not in a position to know who did more than half of the effort. So for the walking items, the person needs to be able to walk the entire distance. So if somebody goes 100 feet, obviously you'd be able to code the 10 feet. Hopefully you'd be able to code the 50 feet with 2 turns if there's turns. But please, for the walking activities, the full distance does need to be traveled. They may not be able to do it on day 1. Let's say they go 100 feet on day 1, but maybe on day 2 they go 160 feet. Then you can code based on the day 2 assessment. So for stairs, it is possible that somebody lifts somebody up the stairs, and so somebody could be dependent, but it's probably not the case that, I could be wrong, but probably not typical that somebody would walk up, let's say, 8 steps and you carry the person the rest of the way in your facility. And so again, if somebody goes up 8 steps but not 12 steps, like in this example, you would use one of the activity not attempted codes. Again, you've got that 3-day assessment period. So if this is discharge and they do it on the day of discharge or the day before discharge, but they couldn't do it, a week before discharge, you would code based on what happened during the last 3 days. But for the walking item and the stairs item, the patient does need to be able to do the activity. And we are actually going to move to the wheelchair items, which is different. So with wheelchair, if a patient is able to self-mobilize 10 feet or 20 feet, but not the 50 feet, I can actually help them the rest of the way. And I will probably make turns, because turns happen all the time during the day, into a room, into therapy, into the bathroom. So please keep in mind that the activity needs to be completed in order for you to be able to determine the assistance required to complete the activity. For walking and stairs, the activity must be completed. And because as a helper, I cannot walk or go up remaining stairs generally for patients. Stairs and walking, again, you may be using those activity not attempted codes for those activities. Okay, so the last activity is pick up object. So this is the ability to bend, stoop from a standing position to pick up a small object, such as a spoon, from the floor. We have an example here. Miss M has Parkinson's disease and is deconditioned following a recent acute care illness and an acute care stay. She has tremors and she drops stuff on the floor frequently. Mr. M, he is highly motivated to perform the activity of picking up spoon from the floor safely. The spoon is on the floor next to the chair. Mr. M bends to pick up the spoon from the floor, and the helper provides steadying support to prevent him from falling as he completes the activity. So how would you code this activity? 03, 04, 9, 88. Okay, looks like most people have coded 04 here. That sounds right to me, steadying assistance. The correct response is indeed 04, helper provides steadying assistance. Moving on to the wheelchair items. So the first question related to wheelchair is actually what we call a gateway question. And it basically asks if the person uses a wheelchair or scooter. If the answer is no, then you actually will be skipping through. You don't need to answer the wheelchair questions because the person doesn't use a wheelchair or scooter. If you answer yes, you'll go on to the next activity. I do want to highlight, we do get questions about this gateway question. Please use clinical judgment to determine whether the person uses a wheelchair. They may be using it for learning how to self-mobilize as a result of a medical condition or safety concern. If a patient walks and is not learning how to use a wheelchair, and basically the staff are pushing the person in the wheelchair for transport purposes only, that doesn't count as wheelchair use. Again, this is all about doing clinical assessments, so just think, if a transport person is taking somebody to therapy in a wheelchair because it's on a different floor or needs to go in an elevator, that's not a clinical assessment. So in that case, if it's just for staff convenience, just transport, you can code no, skip out of the items. If the person is learning how to use a wheelchair, certainly you would be assessing them. So 50 feet with 2 turns starts with the person seated in the wheelchair, and it, of course, includes those 2 turns. We've already covered the turns, so again, could be 2 turns to the left, 2 turns to the right, 1 left, 1 right, whatever. We have an example here. Ms. T uses an electric scooter to self-mobilize. In Ms. T's medical record, multiple clinicians note that she needs supervision and verbal instructions to redirect her using her scooter, so she seems to have some trouble with it. The physical therapist observes that Ms. T's scooter becomes wedged in a corner as she self-mobilizes 60 feet with 2 turns and requires instructions. How would you code Ms. T? The options are 6, independent, 5, setup or cleanup assistance, 4, supervision touching assistance, or 03, partial assistance. All right, looks like most people coded 04. That seems right to me, and that is indeed the correct response. Supervision and instructions in this case. As I mentioned before, there are follow-up questions related to both wheelchair activities. So if you indicate somebody traveled 150 feet with a wheelchair, please indicate whether it was a manual or motorized wheelchair or scooter. There is a follow-up question for each distance because it's possible somebody uses a different type of wheelchair depending on the distance. 150 feet is, once seated, the person's ability to travel 150 feet in a corridor or similar space. The example that we have here, Mr. W is recovering from a stroke. He has right-sided weakness that affects his balance and a chronic respiratory condition that affects his walking endurance. By discharge, he's had a wonderful rehab program, and so he wheels slowly a manual wheelchair 160 feet down the hall without any assistance. He's about ready to go home. How would you code him? Your options are 04, supervision touching assistance, 7, patient refused, 88, not attempted due to medical condition or safety concern, 06, independent. All right, you got it. That's our last example. We wanted to have a good example for a successful rehab program. So I don't think, let's see, So rationale is he's independent. He didn't need assistance. Manisha covered the goals under self-care. So as you know, as part of the quality measures, which we'll be covering after the lunch period, at least one goal does need to be coded, one of the self-care or mobility goals, and so you can code any of the mobility goals here. There are links to the videos available. I believe Bridget covered this a little bit, and I'm sure, actually, I know I've already seen questions about this. So if you download these slides, you can get the links directly, or you can go onto the website and find the videos available that you saw earlier today. There is also online web training on demand available. It is cross-setting, so you would select and indicate your facility, and you would get these 4 lessons available. And in summary, so Manisha and I covered the Section GG self-care mobility activities. I think, one of the important things is these are based on assessments. You've got a 3-day assessment period. If you code one of the activity not attempted codes, that means the activity didn't occur. We covered the item definitions, we coded the instructions, we talked about some key coding points, we did a lot of practice scenarios. Seemed like you did really well. There was just a few questions here and there that a few people didn't get correct. And so at this point, I think I'm gonna turn it over to Bridget, because I think we have a lunch break coming up.